All right, hello and welcome to everyone. Thank you for logging in and joining us for this evening's presentation on the topics of colorectal cancer risk, prevention, screening, and advances in treatment. We have some great presentations planned for you this evening by experts from across our health system, and we're happy to have you join us. My name is Grace Allen. I'm the clinical nurse educator specifically for the Oncology and Outpatient Infusion Center, which is part of the MemorialCare Cancer Institute. Just a few housekeeping items before we start the presentations. At the end, there will be a Q&A with the providers, and we ask that you use the chat box for questions. And then we've disabled all the microphones and cameras except for the presenters and myself. Feel free to ask questions as we go along, and then we will bring them up at the end to our providers. And following the presentation, we'll be sharing more details on FIT screening, which you will learn more about later on. And now we'll move on to talk about the MemorialCare Cancer Institute. Here at the MemorialCare Cancer Institute, we are proud to provide the highest quality comprehensive cancer care for adults and children of all ages. We're devoted to improving the lives of residents in Los Angeles County and Orange County, but also California and beyond. Our cancer centers are located at Orange Coast Memorial Medical Center in Fountain Valley, Saddleback Medical Center in Laguna Hills, and the Todd Cancer Institute at Long Beach Medical Center. Also not listed here, we want to mention our Children's Cancer Institute, Jonathan Jakes Cancer Institute at the MemorialCare Miller Children's Hospital in Long Beach. Our multidisciplinary teams of oncologists, surgeons, nurses, social workers, and other specialists are highly skilled and experienced in the field of oncology. They are passionate about prevention, early detection, and innovative cancer treatments, utilizing the most advanced technology to deliver the best possible care for our patients. Our renowned physicians are experts at treating all types of cancer, including the most complex types of cancer. And every patient receives targeted, customized treatment plans designed for their unique needs, which may include chemotherapy, radiation, surgery, and more. Research and innovation, clinical research is essential to comprehensive cancer care, and we believe in clinical trials are very important and are the front line in winning the battle against cancer. Our physicians are involved in many promising research protocols for various cancer types. We hope you will make it your personal resource for cancer prevention and screening needs. And while we hope you never need us to diagnose or treat you, we are ready to provide you and your families with the very best care available as you make your journey back to health. And now I will introduce our panel of experts that will be presenting tonight. We have Dr. Linda Chan, Medical Director of Radiation Oncology at Saddleback Medical Center, and Dr. Ashkan Fahardi, gastroenterologist at Orange Coast Medical Center. Brittany Kaiser, she's our certified genetic counselor and works at both Orange Coast and Saddleback Medical Centers. Dr. Tam Lee, a colorectal surgeon at Orange Coast Memorial Medical Center, and Dr. Nilesh Vora, hematology, medical oncology, medical director at the Todd Cancer Institute in Long Beach. So we are pleased to have this panel with us, and let's get started with Dr. Fahardi. Oh, sorry, I'll go over. We have a few learning objectives. So by the end of this presentation, our goal is that you understand the importance of routine colorectal screenings as well as current screening recommendations, and are able to describe common types of screenings that are available, also identify the risk factors and signs and symptoms of colorectal cancer, understand how genetic testing works and who can benefit, and understand diagnosis and treatment options for colorectal cancer, including the latest advancements, as well as research and clinical trials. All right, that concludes the introductions and housekeeping, and now we'll move on to our speakers, starting with Dr. Fajardi.
I'm Dr. Ashkan Farhadi. I'm a gastroenterologist, and basically we're discussing today the importance of colorectal cancer screening and its role in prevention of this deadly disease. As is shown here, colorectal cancer is the third most common cancer in the United States and the second deadly cancer in the United States in male and female. Next slide. There are many factors that are important in colon cancer, including diet, the place that we live, age, family history, some chronic condition like colitis, and most importantly, adenoma or precancerous lesion. Obviously, those who had colon cancer before are at increased risk for having another one. Next slide. If we look at the incidence of colon cancer worldwide, we will see there are particular part of the world that have the highest incidence. For example, the North America, US and Canada, Europe, most of Australia, and some part in South America. And we see that the majority of these places are the ones that have the highest socioeconomical level. That means that there is some environmental factor involved in the colon cancer. Next slide. Another studies showed that those people who immigrated from low incidence countries like Japan, when they stay in other countries with higher prevalence like United States, after decades, we see the incidence of colorectal cancer in those individuals inches up and eventually matches to the level of colon cancer in those countries. That is telling us environmental factor is really important in this disease. Next. More and more studies are coming out that are showing the role of meat, different kinds and form in incidence of colon cancer. We see it's almost like a linear line between the daily meat consumption, which goes hand in hand with wealth of a nation, to the incidence of colorectal cancer. Next slide. So, is it only meat or other factors in the diet are important? Definitely meat is just one of them. We know the amount of fat, the type of fat is also important. The amount of fiber, the type of fiber, using vegetable and fruits are all factors that are important in one way or another in colon cancer. Next slide. There are other micronutrients like calcium. Bunch of studies showed calcium usage every day can reduce the rate of adenoma or precancerous lesion. Selenium, studies from China, particularly in areas that selenium is not enough in the soil, showed use of selenium can reduce the risk of colon cancer. Multivitamin, in a very large study of nurses for decades, showed that use of multivitamin for years can reduce the risk of colon cancer. But that should be used for years, like 15 years or more. And antioxidant like vitamin D has no role in that. Use of aspirin, either regular aspirin or baby aspirin, has been shown that reduce the risk of colon adenoma. And we know postmenopausal treatment by hormone can also reduce the risk of adenoma. So beside diet, there are other factors that are in the environment, and we can use them to adjust or improve our chance of having colon cancer. We know obesity. For example, 50% of women and 80% of men that are having obesity are prone to have more adenoma, and obviously adenoma is precancerous colon cancer. There are a lot of myths about colon cancer. For example, constipation. Those who have constipation are more prone to colon cancer. This is a myth. And you see many people that say, oh, I move my bowel every day on a regular basis. I don't have any issues suggestive of colon cancer. That's not the case. Constipation is not a predisposing factor for colon cancer, nor use of laxative is preventive or helping with reduction of colon cancer. We know smoking, particularly when it's more than light smoking, and use of alcohol, particularly beyond social drinking, is associated with increased risk of colon cancer. Beside environmental factor, we know there are some genetic factors involved in colon cancer. So we call this a sporadic colon cancer when it happens in one individual with no background in the family. And we see that there are families that there are a lot of colon cancer, like a clustered in that family. So there is a spectrum of risk factor that include environmental and genetic that can determine the risk of each individual with colon cancer. As you see here in this slide, the overwhelming majority of colon cancer are sporadic. They are not genetic. Sometimes there is one family member, like distant cousin with colon cancer, but genetic form of colon cancer is very small portion. I will not delve more into this because we are having our genetic counselor that's gonna open this part of discussion further for you. Now, we talked about age. We know as we get older, we not only grow, but things start growing in us. And adenoma is not an exception. When we reach to certain age, as we get older, the risk of having adenoma increases as we grow older. Now, a few years ago, like 2 years ago, we used to set the age for colorectal cancer screening at 50. And nowadays, with all these new research, we know we're going to start earlier to prevent colon cancer even more effectively at age 45. Here it shows that how a small growth or dimple that we call them adenoma can grow eventually further into dysplasia and eventually colon cancer. Now, what are our tools against colon cancer? We can screen people to detect those early lesions and prevent colon cancer. One of those is colonoscopy. There are other tests that are also useful is FIT test that is currently available. There is a fecal DNA testing or Cologuard. And there are other less commonly used tests like barium enema or virtual colonoscopy that are only used in special instances and cases. Next one, please. So what is our strategy for colorectal cancer screening? If there's no family history of colorectal cancer, or if there is one family history, but is just at the level of a second-degree relative, or any number of third-degree relative, doesn't matter. The first colonoscopy starts at age 45. If that test is clean, negative, repeat will be every 10 years. As I said, if there is no adenoma, the repeat is 10 years. But what if we find a small adenoma or a few adenoma? If there is a 1 or 2 small adenoma, the interval going to be 5 years. If it's 3 or more, or if there is any large adenoma, the interval could be 1 to 3 years. Now, if there is a first-degree relative, mom, dad, brother, sister, that they had their cancer or colorectal cancer less than age 65, that individual is considered high risk. Or if there are 2 second-degree relatives, like one auntie, one uncle, one auntie, one grandma, the first colonoscopy should be started at age 40 or 10 years younger than the individual who had colon cancer. Imagine the individual in the family had colon cancer, had the colon cancer at age 40, the age for colonoscopy could be 10 years younger or 30. If the colon is clean and there's no adenoma, the interval for this individual is going to be every 5 years. Here it shows a few examples of polyps that we typically see. Some of them look like mushroom that you see on the left-hand side of the screen, that we remove them in the middle, and some of them are like a carpet-like and spreading laterally. I think that would be my slides, but there are some take-home messages here. The first take-home message is, I don't have symptoms. Should I wait for symptoms to get colorectal cancer screening? And the answer is no. When there is a symptom, the horse is out of the barn already. So if you are waiting for changes in shape and the color of the stool, or frequency of bowel movement, or blood in the stool, or abdominal pain, usually that's too late and the colon cancer has already been established and advanced. Next one. So the take-home message is, get it screened. Any way, shape, or form is better than not doing it. But of course, I'm sure the question is going to come up. Colonoscopy at the time is a gold standard test for screening. Thank you.
Hi, thank you so much for having me, everyone. My name is Brittany. I am the genetic counselor at Orange Coast and Saddleback, one of them. And I'm here to talk to you today about hereditary and familial colorectal cancer. So Dr. Fajardi had a graph on one of his slides. I'm very appreciative of that because I think it's something that more people should see. As he mentioned, what we know about most cases of colorectal cancer is that they are sporadic, meaning that we don't really see a familial component, or it's seemingly random. These can be due to environmental triggers. It could be caused by some other type of trigger, but fact of the matter is it's kind of hard to pinpoint a cause for those. Now, if we look at further into this graph here, you can see that the next largest portion is that familial category. And as Dr. Fajardi said, that is the category of people where we might see a cluster of colon cancer or related cancers in the family. But at this time, we can't pinpoint a genetic cause. This is a constantly growing field, so we know that we learn more and more every year. And as we continue to learn more, the hope is that we'll actually be able to find a cause for those familial clusters that we're seeing. Now, the ones that we do have genes for that we know and that we can test for are these HNPCC, which is hereditary non-polyposis colorectal cancer. It's a mouthful, but it's more commonly known as Lynch syndrome for some individuals. About 1 to 5% of colorectal cancer is going to fall into that category. And usually there are some other cancer risks that we talk about that are associated with Lynch syndrome. Now, the other two little spots down there at the bottom are just FAP and the basically polyposis syndromes. So these are going to be things where we're seeing a lot of adenomas for a patient. And that in itself is concerning, just because those are those precancerous lesions that we're worried about. Now, a lot of people want to know, how does genetic testing work, right? We live in a time where there's a lot of direct-to-consumer genetic testing, 23andMe, Ancestry.com, things like that. So for how it works on our end, it's typically a blood draw or a saliva sample. Then we basically look at genes and we can read through the genes that we know of to be associated with colorectal cancer or other types of cancers. When it comes to genetic counseling, we look at a family history as a complete picture. So oftentimes we'll draw out a family tree to get a good idea of what's happening in the family. And if colorectal cancer is something that we're seeing, then we're going to recommend probably looking at the colorectal cancer genes. And at that time, we're going to report results to patients and hopefully take some preventative action steps so that we can hopefully change medical management and catch things early. And so what are the benefits, right, of genetic testing? And what is preventative action? And what does that look like? So that can be earlier screenings, as Dr. Fajardi mentioned. If we know that there is an increased risk of colon cancer due to some familial mutation or change that we're seeing, we might recommend earlier screenings. So as in the previous example, we could be recommending them very young, 30s, 20s. We may also recommend increased screenings, so every other year as opposed to that every 5 to 10 years. Some patients we recommend preventative surgeries for. So for some of those polyposis conditions, patients can be known to have many, many polyps. And in order to prevent that, the burden of that can be overwhelming, not just for the patients, but for our surgeons as well. So it's easier to have these preventative surgical options to help combat that cancer risk. And as I mentioned, we know that a lot of the genes that we look at for colorectal cancer, unfortunately, aren't just for colorectal cancer. So there can be screenings that we recommend for other cancer types. For Lynch syndrome specifically, we often recommend uterine cancer or endometrial cancer screenings for women. If there's a family history of pancreatic cancer, we might recommend screenings for that, so on and so forth. And then lastly, the benefit that I talk about the most, and I always want to touch on, is family testing and awareness. So genetic testing often starts with one person in a family, and it spirals out from there. It can be kind of a cascade effect. And because of that one person who was proactive, so many other family members can get the screenings that they need in order to make the medical management decisions that are required. And so who should consider genetic testing? If you ask me, I say everybody, but unfortunately, the insurance companies don't always like that answer. So typically what we recommend is if there's any personal or family history of colorectal cancer diagnosed under the age of 50, come see us in genetics. Endometrial cancer or uterine cancer, also diagnosed under the age of 50. That's also hopefully an automatic referral to genetics. Additionally, we think of diagnoses of stomach, ovarian, pancreas, bladder, brain, biliary tract, and small intestine cancers as also reasons to be seen by genetics. There's also these sebaceous adenomas, which are of the sweat glands, or hair follicles, and so those can be also kind of suspicious, and we recommend seeing us for that. Suspicious tumor testing. So whenever things are biopsied, it's not just put in a bag and thrown out. It's usually looked into by our pathology teams. And sometimes that testing can be a little suspicious for a genetic change. So obviously for this, it's not something that patients are going to be aware of a lot of the time, but listen to your doctors on if anything comes back suspicious for that testing. And then additionally, if you've heard of anyone in the family that's had multiple colon polyps on a colonoscopy, we're talking 10 or more on a colonoscopy, we recommend them, looking into that as well. I also, usually recommend that if patients have genetic testing, or they can consider it if they're adopted, or if they have a limited family history. Unfortunately, we don't all know every single detail about our family. So when in doubt, speak with your primary care doctor or healthcare provider about genetic cancer risk and prevention programs. And we're happy to see anyone and everyone that is interested in genetic testing. Thank you.
Hi, good evening. My name is Nilesh Shavora. I'm a medical director in hematology and medical oncology, and I'm bringing you today the perspective from a medical oncologist. I think, whenever I see a patient and they're diagnosed with colon cancer, I usually introduce myself as the proverbial quarterback, and that's kind of what my talk will be. We'll be kind of quarterbacking all of you through the stages and the survival of colon cancer. The treatment for all stages and the importance of having a multidisciplinary discussion. And I didn't want to leave without, giving you guys a glimpse into the future. There is the emergence of something called circulating tumor DNA. And I was recently at a conference where I was really mesmerized and wowed by by how powerful this data could be. And I want to show you kind of a sneak peek of what circulating tumor DNA means and how it could help us in the future. Next slide. So the title of this slide is, so the colonoscopy was positive for malignancy. Now what? And that's generally speaking when I get to meet patients is when we start the workup for colon cancer. And I think these steps are really key as we move forward in understanding the stage of a patient and also the treatment that should be offered for patients. So I mentioned here a CT scan of the chest, abdomen, and pelvis. A lot of times I see patients and they've only had a CT scan of the abdomen and pelvis, but I think the chest is just as important in making sure that cancer hasn't spread to that area. There's a basic set of labs, including a complete blood count and a complete metabolic panel, and then something called a CEA. A CEA is a protein that we can measure in the bloodstream, and we call it a tumor marker. And it's not the best form of measuring someone's tumor, but it gives us an idea of how advanced a cancer could be. I think one of the most important things is an early referral to a medical oncologist. Even if this looks like a surgical plan, having a quarterback to sort of be the person to guide you, I think is really important, not only during the time of workup, not only during treatment, but even after treatment's done. Having somebody be your quarterback like a medical oncologist, I think is very critical. And then, of course, a referral to a surgical oncologist if surgery is being considered. So these are the treatments of colon cancer by stage. And if you look at stage, we'll go over what each stage means. But stage 1 in general means surgery. And so that's when a patient doesn't have lymph node involvement or an advanced type of colon cancer. Stage 2 means, again, lymph nodes are not involved, but the cancer's gone through the first layer of the colonic wall and into the muscularis layer. Stage 3 is when the lymph nodes are involved. And again, this is found during surgery. A surgeon will sample lymph nodes and a pathologist will reveal whether there is involvement of cancer. And in all stage 3 patients, chemotherapy as of right now is recommended if a patient's fit enough to receive chemotherapy. And then stage 4 disease. So stage 4 disease means that the cancer has spread to other organs. The principle of treatment for stage 4 disease is chemotherapy. And there are some cases of metastatic stage 4 cancer where surgery could be beneficial. Again, it's really important to have a quarterback on your side to go ahead and guide you through the different types of treatment. Next slide. And this is important because this really shows you the differences in 5-year survival rates between stage 1, stage 2, stage 3, and stage 4. And this echoes what Dr. Farhadi was mentioning about the importance of colon cancer screening. Many times, stage 1, stage 2 colon cancers have no symptoms at all. And finding them at these earlier stages can absolutely impact your 5-year survival. The difference between a stage 1 or a stage 2 colon cancer can be a survival difference of 92 or 87% versus stage 4 disease, a 5-year survival of 11%. Next slide. So the question is, what is circulating tumor DNA? And as I mentioned here in this slide, this could be the next big thing in oncology. And I think it's really critical to just look at this as potentially something that we can use in the future. So just an introduction to what circulating tumor DNA is. And what you see here are examples of cancers that are growing and dividing. And as they're growing and dividing, they're shedding their own DNA, in some cases, into a patient's bloodstream. We have the technology now to be able to sample a patient's bloodstream and monitor and check for circulating tumor DNA. That's DNA that's not the same as a patient's normal DNA. It's different. Next slide. And this is more of that diagram. So as I said, the tumor grows and sheds its own DNA into a bloodstream. And we now have the ability to monitor that. And so I'm calling it circulating tumor DNA for MRD assessment. MRD means molecular residual disease. And so a patient who has cancer may be circulating tumor DNA positive, meaning that they're detectable, or circulating tumor DNA negative. It's a wonderful tool. The question is, what do we do with that? Next slide. This is how circulating tumor DNA is found. So a company like Natera is an example of one. And I think this is really interesting. I don't want to make this too complicated, but I want to really give you guys a glimpse of how this is designed. So a patient's tumor is sequenced. That means the cancer's already been removed. That means this company or another company will look at clonal mutations of the tumor. They'll look for 16 mutations that are found in the tumor, but not found in a regular DNA sample of the patient's blood. And from there, 3 or 4 weeks later, a custom designed assay for each patient's design is made. And then you can take a patient's blood sample and look to see if they have circulating tumor DNA floating around or not. So this is great because it's really personalized. You can't use one assay and extrapolate it for another patient's assay. It really comes down to that specific patient. And then you can monitor and check whether a patient has positive DNA or not. Next slide. So this was data that was presented at ASCO GI in 2022. The Japanese group published their observational study. This is a really incredible study. Again, I want to simplify this down. They took patients with colon cancer who had undergone surgical resection. They checked their circulating tumor DNA pre-operatively, and then after surgery, they checked them every 3 months and presented their data in this observational fashion. Next slide. And these are the graphs. And I think these are fascinating graphs. So again, I want to simplify this down as much as possible. The y-axis is disease-free survival, and the x-axis is months after surgery. These patients had a single time point in which they were checked for circulating tumor DNA, and then they were observed. And what you can see is in the green line, if they were circulating tumor DNA was negative or MRD negative, at the 1 year mark, they had a 95% chance of being disease-free. Whereas if they were circulating tumor DNA positive at that time in which it was checked, the chances of being free of disease at 1 year was only 55%. Fascinating data from a prognostic perspective. Next slide. So the question is, what happens to each of these patients? So let's take the circulating tumor DNA or MRD positive patients. Next slide. Can we help these patients? And these curves are fascinating. Now the green line are patients who received chemotherapy, and then the blue line are patients who didn't receive chemotherapy. Again, y-axis disease-free survival. And what you see here is a difference because of chemotherapy. Patients who received chemotherapy, whether they were stage 2, stage 3, or stage 4, had a beneficial response if their circulating tumor DNA was positive at that time that it was checked. Next slide. This gets even better. So let's look at these patients who were circulating tumor DNA or MRD negative. Did these patients benefit at all from chemotherapy? Next slide. And look at these curves. So again, disease-free survival. These are patients in green who received chemotherapy and the patients in blue who did not. And you can see by the 12-month disease-free survival projections that chemotherapy didn't benefit these patients. So all of a sudden, we're generating some hypotheses. We need to do validated studies with this technology, but we might be able to determine whether a patient really needs chemotherapy or not using this personalized assay called circulating tumor DNA. Next slide. And this brings me to a very important clinical trial that I'm proud to open across the MemorialCare system. It's called the NRG GI 008 study. And in this specific study, we're taking patients with stage 3 colon cancer, and we're checking their circulating tumor DNA immediately within 6 weeks after surgery. If their ctDNA is not detected, they are randomized to chemotherapy or just surveillance. This is a prospective study that will answer the question of whether every patient with stage 3 colon cancer needs chemotherapy or not. Conversely, if their ctDNA is detected, they're randomized to either standard chemotherapy like they normally would have gotten or an escalated form of chemotherapy. And again, what we're asking here is, can we change the natural history of these patients using a more intense form of chemotherapy in patients who we're worried about. So with that, I will end our discussion and I'll be available for questions at the end. Thank you.
So my name is Linda Chan. I am Medical Director of Radiation Oncology here at Saddleback Memorial, and it's lovely to meet all of you virtually over Zoom. Sorry about my earlier microphone issue. Next slide. So a lot of people understand what surgery might mean or what chemotherapy might mean, but a lot of people are very confused about what radiation therapy means and how a radiation oncologist is part of the team. So I would like to discuss that. But the first thing I wanted to address is the picture on the left, where you can see the colon and the rectum lower down. Earlier, as Dr. Vora mentioned, surgery and chemotherapy are the mainstays of treatment for colon cancer. But for radiation therapy, I mainly come into play more for rectal cancer. So that's for cancer lower down in the GI system. The picture on the right is basically a picture of our center at Long Beach Memorial. That is what a radiation machine looks like. It's called a linear accelerator. And that's just a fancy medical name for this machine that produces an invisible beam of x-rays, focused x-rays, kind of like a very focused laser beam that can specifically target cancer cells. So one way that I like to think about radiation is that you can imagine that I am almost like a surgeon that never touches you, in that radiation is very focused, very targeted, and we can try to avoid the normal structures next to it. So what a radiation patient might experience is that they might lie on this table, this machine moves around them, but it never touches them. So radiation is invisible, it's painless, you feel nothing, you can't see it, you cannot touch it, you cannot feel it. The other nice thing about radiation is that it's very quick. So I'm probably one of the fastest things you'll ever experience in a medical center, in that radiation delivery is usually less than 30 seconds. It's very fast, but the patient might spend a total of about 5 minutes on the table. But again, it's completely painless. They have no sensation. It's one of the easier types of treatments to go through. Next slide. Now, how exactly does this work? So on the picture on the left, we have that same patient. And if you can imagine you are Superman with X-ray vision, if you can see through them, then you can target where that tumor might be. So on the cartoon that I have on the left, the tumor is that red circle. And as you can see, the radiation beam is invisibly passing through the patient to reach the tumor and then exiting out the back. And oftentimes, especially with modern radiation technique, I can design hundreds of beams that come in from different angles, each beam incredibly small in intensity, each beam individualized to conform to the shape of the tumor, because tumors are often not as nice as these cartoons where they're round and easy to measure. Sometimes tumors are like an octopus with little tentacles that come out. We can individualize the shape, size, and intensity of the radiation beam to match the patient's individual tumor. And at the same time, there are cameras and other equipment around the patient that also can track the tumor movement. And that's because of one really interesting thing, which is that if I tell you to lie still on my table, even if it's only for 5 minutes, the patient may lie perfectly still, but internally, everything is moving. The heart is beating, the lungs are inflating and deflating, and if it's in the rectal area, there may be gas or stool moving through the system, causing movement of both the tumor and the normal structures around it. So again, in this cartoon on the right, you see the little discs on the side of the patient. Those are discs that help me see internally in the patient to see where the tumor may be so that I may modulate the radiation accordingly. So if you can imagine my fist is the tumor and it's moving because all of your normal structures inside are moving, then if my finger is the radiation beam, if the tumor moves, I can also move my radiation beam in accordance with the tumor, such that we can be much more precise and accurate with our radiation. And also, just as importantly, try to avoid hitting any normal structures next to the tumor to minimize the risk of side effects or damage. Next slide. So If you look at the cartoon on the left, again, that's that invisible beam of radiation passing through the skin, through the normal tissues to get to the tumor. On the right is actually a picture of a real life example of a patient. And what you can see is that the areas that are drawn in red, it's a little small, but if you can see in detail, the areas drawn in red are some of the lymph nodes that are of concern. And the area drawn in orange is the area that we want to sterilize of tumor. So earlier, Dr. Vora mentioned about how he's quarterback. He's an amazing quarterback. I think I have more humble aspirations. I always like to joke that I'm the cleaning lady in the medical team. So my job is to clean, to sterilize this area where the tumor may be, but then just as importantly, where there might be microscopic cells that have migrated out of what we can see where the tumor may be, to clean that whole area to minimize the risk that the patient faces cancer again. So the area I've drawn in orange and blue is the area that we're trying to clean, to try to sterilize of any microscopic tumor, in addition to the visible tumor that we can see with the naked eye. Next slide. So this is a very complicated slide, and I apologize, but it gets to one point that I wanted to make, which is that the nice thing about radiation, like I said earlier, is that it's invisible. You don't feel it. It's only 5 minutes. But the hard part about radiation traditionally is that it's been 5 minutes a day, every day, Monday through Friday, for multiple weeks. So a typical rectal cancer course, for instance, might be 5 minutes a day, Monday through Friday, for 6 weeks. And that's a long period of time. But for certain types of rectal cancer patients, which is detailed in this very busy slide, we've now been able to have significant advances in our radiation technology such that we offer only 5 days of treatment. So it's just 5 days where they come in for 5 minutes, again, feel nothing, it's painless, but then we give a high intensity dose of radiation to clean, to sterilize that whole area, to help improve the local control of the tumor and improve the patient's survival. Next slide. So thank you so much, and I will also be available for questions at the end.
My name is Dr. Tam Le. I'm a general and colorectal surgeon. Good evening, ladies and gentlemen. I want to let you all know that despite all the talk we heard, for patients with colorectal cancer, you can be cured with combination of treatment with chemotherapy, radiation therapy, and surgery. The cure rate depends on your stage, as you heard from Dr. Vora. I will focus on the surgery aspect of it. Surgery for colorectal cancer consists of 3 approaches. Open surgery, been around for a long time, but it's painful and it requires long recovery. It's very safe and often it's required when the other techniques are not possible. Laparoscopic surgery and robotic surgery are minimally invasive, require small incision. They are less painful and you recover quicker. Now for robotic surgery, it's very important for treatment of rectal cancer. Laparoscopic surgery are very effective for treatment of colon cancer, but it's not very effective in treatment of rectal cancer. Next slide. For purpose of treatment, the large intestine actually consists of 3 distinct areas: the colon, the rectum, and the anus. The colon is the upper area, flexible portion of the lower gastrointestinal tract. The rectums are more fixed. It's in the pelvis. It's narrower area. And then the anus is, of course, the end portion of the gastrointestinal tract. Next slide. Now, for colon cancer surgery, it's important to remove the tumor, the surrounding tissue, and the lymph nodes, as well as associated attached organs. If a tumor on the right side, we can move the portion of the right colon, or if on the left side, you do the left, or you do in the junction between the rectum and the sigmoid colon, you can remove that portion, or it's in the middle portion, like in the transverse colon, you can remove the transverse portion of the colon. Now, very important to minimize the risk of complication like infection and connection disruption that bowel preparation and antibiotics are given. So the most important activity the patient can help is to do bowel preparation before surgery. Rarely ostomy may be required, but we try to avoid ostomy unless the bowel is obstructed, the rupture. Well, you heard from Dr. Vora, depending on the pathology, my job to help get the most out of surgery. So depending on the pathology, the lymph node status, patient may require chemotherapy. Radiation treatment is rarely required for colon cancer. Next slide. Now for rectal cancer, very important to save the anal function and the sphincter to avoid permanent colostomy. This is one of the issues that many patients with rectal cancer are concerned about. So radiation treatment play a very important part in treatment of rectal cancer, as you heard from Dr. Chan. Patients often require chemotherapy and radiation therapy before surgery. Now, as far as surgery technique, it's very important that the surrounding tissue is to be removed completely. It's called the mesorectum. So the mesorectum has to be removed totally to minimize the risk of cancer recurrence in the future. Now, the connection has a high incidence of disruption. So usually protection with a temporary, not permanent, temporary diversion using the small intestine called ileostomy is required. Anyway, my other point quickly is for anal cancer, treatment mainly chemo and radiation treatment. Surgery have very little role unless it's very advanced for palliation. So my take-home point is prevention is important. Surgery is very morbid. Prevention is achievable and prefer, as you heard from Dr. Fahady, an ounce of prevention is a pound of cure. So make sure you prevent development of colorectal cancer. Even with stage 1, if you heard from Dr. Vora, the cure rate is not 100%. The only way we prevent 100% prevent cancer and have a 100% cure rate is with screening and early detection. Thank you.
Thank you so much to all of our panelists for the information. And I hope everyone viewing this presentation learned something new. I know I did. Okay, so our first question, are there new treatments coming out for advanced colon cancer that can provide a cure for patients?
I can probably answer that. And I was able to read through the chat box about this patient's case, and I don't want to go into specific details, but there's something I'd like to highlight on that, which is that a KRAS G12C was found in the molecular profiling of the particular tumor. And I think that highlights this point that we really are doing a lot more with molecular profiles of patients' cancers, that, it's not just one size fits all, and finding a mutation can lead to a really, really nice outcome, something better than just kind of generic chemotherapy that we sometimes have to do for patients. So I think in advanced colon cancer, I think it's really important to have that tumor sequenced completely and tailor the treatment towards that if indicated.
Thank you, Dr. Vora. And our second question, this one for Dr. Chan. Can someone who previously had SBRT, a type of radiation for prostate cancer, have radiation for rectal cancer?
So the devil is in the details. The old teaching was that once you received one course of radiation, that you could not receive that again. But thankfully, we've been able to break that rule many times over now. So I think in general, the answer is yes. However, I would need to look through the details of exactly when one received the prostate SBRT, where that was located in terms of where the prostate was in approximation to the rectum, and how much the rectum got dosed before. But generally, my short answer is yes, you can.
Okay, thank you, Dr. Chan. And our third question, is there a website or book that you would recommend that could teach us what food to eat or not to eat in order to help prevent developing polyps? Maybe Dr. Fajardi? Oh, you're on mute.
Could you repeat your question one more time?
Is there a website or book that you would recommend to guide on what food to eat or not to eat to help prevent polyps?
Well, that's a really good question. Basically, what I presented here is the hand-picked studies that's been reviewed, but have them under one umbrella. Unfortunately, not that I know that exists. And there are sometimes some websites that pretend or claim that they have diet for this, diet for that. Most of these are not substantiated scientifically. And there are some word of caution that maybe there is a string attached or something. So not that I know, but definitely there are books that you can verify the authenticity of those and see if you can find them. But I do not recommend anything personally.
Okay, I'll go to the next question. Is there an advanced age at which screening is no longer considered beneficial?
That's another good question. I may answer that question. Typically, based on the insurance regulation, which is, of course, after societal recommendation, we are screening people from age 45 to 75. That means that whoever their interval falls after 75, typically, we cannot recommend surgery. Where this number 75 came from? Basically, if you do remember, if I said if your colon is clean, your next one would be in 10 years. And imagine, hypothetically, the average expectation of life in the United States is 85. So basically, the math is correct. So if I do your last colonoscopy at 75 and give you 10 years warranty, basically by the next time, based on math, that individual, if has colon cancer, wouldn't be expecting more life. But having said that, not everyone live up to 85. There are people who you see in your office that look, even though they are 80 years old, they look like 70 or 65. So basically, they left some leeway here, and they are telling if the physician justify in their request that they see 10 years prospects of life ahead of that individual, the insurance has to pay for the screening even after 75. But the answer to that question generally is 45 to 75.
Okay, thank you. And then there's a specific question about two small polyps. If the patient is 76, would you recommend a colonoscopy?
I think that's exactly fairly similar to the question that was asked before. So again, if the physician do not see 10 years prospect of life ahead of anyone after 75, I don't think it's a service to that individual to offer colonoscopy. Give you an example. Someone comes to me with congestive heart failure, with lot of comorbidities, cardiac condition. And you may consider, if I just put this person to sedation or anesthesia, am I doing him a service to find a polyp and cutting his life short by just not having complication on that individual? It's possible. So most likely after 75, we do not do a screening unless we can justify that individual has at least 10 years prospects of life ahead of him.
Thank you. Our next question, in general, are you seeing younger patients diagnosed with colon cancer?
Yes, unfortunately, I do. And over the years, I've seen that trend. So that's why I'm glad that we reduced the screening age to 45. And I think eventually we may have to reduce that even further, because it's most productive and effective, I think, to treat and prevent cancer in the early age population.
Okay, thank you. And it's 6:36, so we'll just take 2 more questions before we close the presentation. In the chat, how long does it take colorectal cancer to spread outside of the colon?
Well, I think I can have a first jab at it, but I will ask Dr. Vora to complement that. It totally depends. The rate of growth in different individual is astonishingly different. I have patients that every year I do colonoscopy and they grow a big chunk every year. I have a patient who I asked them to come 1 year later because they had a big polyp. 10 years later, there is nothing. So I think it's so individualized that I can answer that question that easy. But we know the colon cancer is not one of the rapidly growing cancer. This is why, despite its lethal demeanor, it at least gives us time to screen people and cure people and remove things before it reaches the level that we cannot do nothing.
Yeah, I would echo you, Dr. Farhadi. I mean, I think, one of the things I talk about with patients is if you have a negative colonoscopy, the guidelines are to repeat your colonoscopy in 10 years. That really gives you a kind of a frame of mind of what the general rate of growth is for colon cancer, from polyp to invasion. And that sort of rate of growth echoes even if you have an invasive cancer. You may be, a stage 1 colon cancer, and it doesn't mean that, 2 weeks later you're going to be metastatic. So I think that becomes a really important lesson as patients are diagnosed with cancer. The thoughts are, well, I must get everything done immediately because I have cancer. No, what I think needs to be done are the steps in a proper workup, a CT scan, labs, all those things need to get done so that we can figure out exactly what stage a patient is and treat them accordingly. So I agree. However, I think the caveat is, this is a general answer that there are some types of cancer that behave a little more aggressively and a little less aggressively than others in the field of colorectal cancer.
Okay, thank you. And our last question, this one's for you, Brittany. I was diagnosed with Lynch syndrome in 2018. When will be my children's next genetic screening, or when would you recommend?
Yeah, that's a fantastic question. So if there's already a known genetic change in the family or mutation that has been found, we recommend testing for all first-degree relatives. So that's children, siblings, parents. Usually we wait until, age of consent, typically 18, but it can vary depending on the family history. If they have already been tested for the family change and that has come back negative, the good news there is that is a true negative. So we actually don't recommend any further testing. We would consider them to be at the average population's risk for those cancers.
Okay, thank you so much. And thank you for everyone who logged in to join us for tonight's presentation. We hope you found it valuable and informative and that you learned something new, and have a wonderful rest of your evening.